Thanks for coming out tonight. I see we got a fair amount of folks, almost close to 100 now. So thanks for everybody for taking some time out of your evening. Today's talk, as you may already know, is talking a little bit more about kidney stones, kind of the etiology, causes, treatment options, things that you can do to avoid kidney stones. We'll kind of touch on all these things tonight. Feel free throughout the presentation. If you have questions, there is a chat option. You can send these in. I'll try and get to most of them sort of as we're going along, but we'll have some more time at the end to go through them. So again, thanks for taking some time out of your evening to come chat with us. So just quickly about myself, I am with the urology group, primarily in the kind of Fairfield, Hamilton, Butler County pod, a little bit farther north. Went to Georgetown for my residency, did some time at Vanderbilt as well with the surgical general surgery internship year. Fortunately or unfortunately, depending on who your teams are, I did go to Notre Dame for undergrad and med school at Louisville. My focus is pretty broad. I am a general urologist, but I focus a lot on kidney stones. That's probably my primary area that I'm a little bit more passionate about. Not only just the surgical treatment, but really prevention, being proactive with these things. It's a very common condition, as we'll talk about. So that's kind of been one of my passions and kind of my niches that I've carved out over the last couple of years within practice. Also do some robotic kidney cancer surgery, kidney reconstructive surgery, again, benign enlargement of the prostate, overactive bladder, and vasectomy tend to be a couple other areas that I kind of specialize in. So kind of starting off with the real superficial stuff, what is a kidney stone? So the kidneys are two structures that kind of sit in an area in your back called the retroperitoneum, just a fancy way of saying an area sort of tucked in the back behind where all your intestines are at. They filter your blood into urine. Over time, you can get some little crystals that form within the kidney. A lot of times those just get excreted through your urinary tract. Other times, they will start to get a little bit bigger and can deposit. It can stay in the kidney just as what we call non-obstructing renal stones, or they can drop down into the ureter, which is a little thin drainage tube that drains all that urine from the kidney down into the bladder. So when you have these stones that are causing blockage, those are generally the patients that know that they have something going on that end up either in the emergency department or in our office with really severe urinary symptoms. The obstruction of the kidney is actually generally what causes the pain with kidney stones. The urine not being able to drain is oftentimes which can cause infections. And when you have an infection and a blockage all at the same time, that can be a pretty big deal that sometimes requires an emergency surgery to deal with this. Kidney stones are a lot more common than most people realize. It is about 1 in 10 people that will develop a kidney stone at some point in their lifetime. So this is just a representative picture of a kidney. You kind of see the outer lining of the kidney, the red stuff with all those kind of circular areas. That's kind of what I call the meat of the kidney. That's what does really the function of the kidney, filtering that blood and creating urine. That middle area where you see more yellow and a couple little calcifications in there, that's what we call the collecting system. So all the urine that gets filtered from the kidney it drains into that area and into a more thin tube called the ureter, which again, where you see a couple little stones that are blocking on this picture. So kidney stones can be tiny little grains of sand all the way up to essentially filling the entire collecting system of the kidney. And really, that's kind of what pushes us in certain directions to either observe kidney stones or to do something, or exactly how we approach them from different surgical standpoints. So there are multiple different types of kidney stones. The most common type of kidney stone is what we call calcium oxalate. There are a couple of different types of calcium oxalate stones, some that are a little harder, some that are a little bit softer. But there are obviously a couple of different chemicals that combine to form these crystals. A lot of reasons for that. Sometimes, generally we'll tell people, hey, cut back on calcium and cut back on oxalate containing foods. And we'll talk about a little bit more upcoming. And some people with really low levels of calcium can actually form stones. One of the other more common types of stones are uric acid stones. These tend to be a little bit softer, which make our job as surgeons a little bit easier. Patients that have really high animal protein diets, what we call high purine diet intakes, tend to have more of these uric acid stones. Obviously, patients that have gout tend to generally have higher levels of uric acid circulating. So there certainly, are dietary things that we can do to really help with that. Some less common types of stones, there's something called a cysteine stone, which is a really, really hard type of stone. Patients with a genetic disorder that have some amino acid metabolism issues can actually have some pretty significant kidney and liver dysfunction. Rarely, patients that don't have those mutations can actually have cysteine stones. And then struvite stones are a little bit less common than the uric acid and calcium oxalate, calcium phosphate stones. Generally are caused by patients who have recurrent urinary tract infections. There are types of matrix stones, which are kind of like webby stones that kind of hold on to bacteria, can cause patients to have the same symptoms as kidney stones, but also generally recurrent urinary tract infections. I do see a couple questions here, kind of talking about different dietary changes and medication. So we will go into that here in just a little bit. Patients that are kind of talking about, hey, I have a lot of spinach in my diet, a lot of leafy greens. That tends to be really high in oxalate content. So with patients who have really high leafy greens, nuts, teas, those tend to be high oxalate containing foods. Those certainly can contribute to calcium oxalate related stone events. There's also another question about medication, what we call potassium citrate. That's a medication that will help increase urinary citrate and can change acidity in the urine. This is also a medication generally that is pretty helpful. Most of the time we're prescribing that twice a day. And we'll go into a little bit more detail as we get into more prevention. So kind of more on the surface, who are patients that get kidney stones? So in general, Caucasian patients that are not drinking enough water, that tends to be one of the more common and low-hanging fruit types of things that we'll tell patients. Anyone who's got a family history of stones, anyone that's had a personal history of stones. I usually tell folks if they've had a single stone episode, they're about a 50% risk from having another kidney stone in the upcoming year. So those tend to be patients when they're younger with their initial stone episode, strong family history of stones, or patients who have had stones in the past, that we tend to be a little bit more aggressive about some of these preventative measures, running other tests, being a little bit more strict with dietary changes. So in general, hydrate a little bit better. We could all probably use a little bit more water intake and mainly sticking with water rather than a lot of other types of drinks. Really sugary foods, patients that eat really high animal protein diets, high salt intake, high calcium, high oxalate containing foods, which we kind of touched on a little bit. During the pandemic, we actually saw a little bit more of this, but patients who take really, really high levels of vitamin C supplement and what we call super therapeutic levels, just taking in way too much and the body can't really process it. Sometimes that can actually turn into oxalate, and your kidneys are smart and sense all that excess and start to excrete it. So some patients, again, can almost have a vitamin C toxicity by taking too many supplements. Patients who have had prior bypass surgeries, that does tend to alter the gastric and kind of intestinal secretion of certain compounds. So patients who have had those types of bypass surgeries certainly can be a little bit of a higher risk. So you see a little bit more common in men, but overall about 1 in 10 patients, 1 in 10 folks will have a kidney stone at some point. So most of the time, patients who have a kidney stone that lodges in the ureter, which is what we call an obstructing stone, generally they're going to know. They're going to have pretty severe symptoms, and the symptoms can be a bit more wide-ranging. Usually it's with associated flank pain, but some patients have more pain in the back. Other patients will have more kind of lower abdominal pain. Other patients will have a pain that sort of radiates down into the bladder, into the labia, into the testicles. And that's really just because the nerves that feed that drainage tube, the ureter, really come from a lot of different areas. So the pain can be anywhere from the back all the way down into the groin. Most patients, their bodies will sense that blockage and have, nausea and vomiting and kind of these waves of what we call renal colic or colicky waves of pain. Other things that you can have, which can be a little bit more subtle, is some patients will just have a more abrupt change in urinary symptoms. When the kidney stone gets lodged really close to the bladder but hasn't quite passed, it can cause a lot of irritation within the bladder, almost making patients feel like they have a urinary tract infection. So urinary frequency, urinary urgency, constant needing to go and just getting small volumes out at a time. Those tend to be more common with what we call distal stones, or stones that have moved a little bit farther down the ureter. Blood in the urine is another thing. If patients are coming in with blood in the urine, there is a whole host of different things that can cause that, but one of those is certainly kidney stones. So there are typically workups that you come to see your urologist for if you have blood in the urine, and we get CT scans. oftentimes we'll do scopes to kind of look into this a little further to make sure that there's not something easily correctable or something that would be a clear cause of the blood, like a kidney stone. And so really, the size of the stone is not necessarily as important at times. Really small stones that are blocking the ureter, if they're able to block the ureter, patients have very, very severe pain. Just because you have super severe pain doesn't necessarily mean it's a big stone or a small stone. So even tiny stones that are causing blockage can certainly cause really severe symptoms. If there's an infection going on at the same time, again, I had mentioned before, if there's infection and blockage, usually we need to do a little bit more of an urgent surgery to get any of that infected urine drained out of the kidney. So typically what we'll do, and obviously get some imaging tests. Most of the time, a CT scan is really the gold standard for looking at size and number and location of stones. So most of the time when you have that diagnosis, we'll have that CT that kind of tells us what do we need to do. So again, we kind of mentioned some ways of reducing your risk. I tell patients, whatever you need to do to get to about 2 to 2.5 liters of urine output throughout the day. It is a little bit more fluid intake than most people will appreciate. And I have a lot of folks that come in and say, I feel like I'm drinking all day. And then I run a urine test that says, hey, you're drinking like 10% of really what you need to be drinking. So, really increasing primarily with water. There are some studies that say lemonade, and in particular lemon juice in water, it can be helpful for prevention for certain types of stones. So I think if water's a little too boring for you, water with a little bit of lemon juice can be helpful. Usually around this time of year and into the summer, we start seeing a little bit of an uptick in kidney stones. People are outside sweating a little bit more dehydrated, not drinking as much water as they should. So again, usually summertime, our office and waiting rooms stay plenty busy. So just make sure you're hydrating well. That I think is probably the biggest takeaway in terms of diet hydration changes. However, depending on what type of stone you have, and depending on what your urologist says, there are a handful of different dietary changes that folks can make instead of having to jump necessarily to medications. We had kind of mentioned foods that are high in oxalates. There's a list here. Leafy greens, nuts, spinach, chocolate, certain types of wheats, oats, beets, tea, and dark sodas tend to be big offenders as well. For patients that really want to go down a big rabbit hole and learn a lot more about oxalates, this tends to be the most nebulous out of all the dietary changes that we recommend for patients. But the Harvard School of Public Health put out a really nice review of high oxalate containing foods. In general, we want people eating a nice, healthy, well-balanced diet. So I'm not going to say, hey, you can't have salads, you can't have nuts. But if you're saying, hey, I really don't care what type of leafy green I'm taking in, or what type of, cashews versus pecans, whatever it may be, the Harvard School of Public Health has a really good over-the-top spreadsheet with lots of data, lots of information. So, I think that's helpful if you do have calcium oxalate stones, or your urologist is specifically counseling you to, focus more on your oxalate intake. So we want you eating enough dietary calcium, but also avoiding too much. So again, a lot of American diets pretty high in dairy, milk, cheese, yogurt, ice cream, those types, all the good stuff. So, we want you eating an appropriate amount where you're not having bone mineral density issues and osteoporosis related issues. But we also, don't want you taking 15 different calcium supplements and eating a ton of dairy and drinking a gallon of milk every other day. So, your kidneys, again, they're very smart. They recognize you have tons of calcium on board. They'll just start dumping that, and that starts to form some crystals, which can then ultimately result in kidney stones. So we had mentioned before, animal protein, we want you to eat a moderate amount of that. Super high levels of protein can cause increase in calcium excretion, can also cause some uric acid stones. The other thing that I think that the typical American diet is pretty guilty of is generally pretty high salt intake. And I see this on a lot of patients that we're doing more workups on to kind of get to the underlying cause of these stones. So high salt diets, while not great for your blood pressure to begin with, will actually convince your kidneys and sort of trick your kidneys into excreting more calcium, which again is kind of doing the same thing as if you're taking a bunch of dietary calcium in, whether it's supplements or whether it's high dairy diet. And we, again, had mentioned super therapeutic doses of vitamin C, really avoiding that if at all possible, just to decrease the amount of calcium oxalate or amount of oxalate that is excreted by your kidneys. So there are some questions here, kind of talking more about herbal teas. Any teas can have some oxalates. What I would recommend if you have a very specific type of tea that you like to drink is, again, referencing that Harvard School of Public Health. It's a super exhaustive list. If you're saying, you know, I've had multiple kidney stones, but I really like tea. I like the health benefits, the antioxidants. I just like the taste of it. Go to that list and kind of do a little bit more reading because, again, there can be certainly some that are a little bit better than others. There's also another question about carbonated water, San Pellegrino. There's a lot of different flavored waters. I tend to be, in general, a pretty big fan of doing that, especially when I'm telling patients that they need to double their water intake. I think it's a really nice way of increasing that without making it too boring of just drinking water all day long. So what I would say is pay attention to the active ingredients, whether it's in your diet or whether it's, you know, in some of these fluids that you're drinking. Some of these, not necessarily carbonated waters, but other sports drinks tend to be really high in sugar, really high in salt. So we want to avoid those. A lot of the carbonated waters tend to have pretty minimal sodium in them. So in general, I'm perfectly fine with that. What you could even do is, again, add a little bit of lemon juice in there. So those are things that you can kind of do to help get over the fact that water is not the most exciting thing to drink all the time. A couple other questions, you know, salads, nuts, are these all bad? No, it's, you know, selfishly as urologists, we say, here are the ways that you can decrease and mitigate your risk of forming these stones. However, we don't want you going out and eating junk food all the time. So it's kind of a balance of eating a healthy, well-balanced diet. But if you know that you have a, you know, in particular, calcium oxalate stones or uric acid stones, really making those targeted dietary recommendations. I tend to be more of a proponent in patients who have had multiple stones of actually doing a test called a litholink. What that is a 24-hour urine collection that really gives you more of a customized, tailored approach to figure out how can, you know, you as the patient in particular do better to prevent these stones, right? I can have you, you know, review this list of all of these potential causes. I don't think it's as helpful as actually getting a litholink test and figuring out, you know, particular to each patient and really customizing, tailoring that approach, you know, to each patient's diet to say, okay, in your case, you don't really need to make any drastic dietary changes. You just have to double what you're drinking. Or, you know, your calcium levels are through the roof. Let's look at some of your supplements, some of your medications, some of those things that you're eating and drinking throughout the day, and kind of paying attention to some of those nutrition labels. So I like the litholink to give a more customized approach. I think it makes a lot more sense. However, I think in general, just being aware of some of these dietary triggers is really an important thing. You know, and kind of moving a little bit forward here, how are kidney stones treated? So obviously we like to have some sort of imaging first to prove that you have a stone. And what that will allow your urologist to do is say, you know, from here, what is the size? What is the location? You know, what do we need to do? A vast majority of stones that drop into the ureter tend to be smaller. And when stones are generally less than about 5 millimeters or so, those tend to pass on their own. Once they're above 5 millimeters, that likelihood tends to go down. You know, some patients are able to pass really large stones. I have some patients that have passed stones as big as a centimeter or sometimes more. That's a lot less common. But if you're one of those patients that's passing multiple stones a year or a month, some of those patients tend to have a higher likelihood of passing, you know, future stones. So I'll have patients that'll come in and say, I have never been able to pass anything. I've needed a surgery for everything. So again, still 20% of patients who have these smaller stones still may require, you know, surgery. And it's not something that just happens overnight. That's the other challenge. And I think some of the misinformation occasionally that patients will get from the ER, you go in, you're miserable. They tell you you got a stone and that you got to go see urology and hopefully it passes in the next couple of days. Well, if the stone just drops, sometimes it can take 2, 3, 4 weeks before it actually passes. So there's certainly a balancing act between saying that every patient with a kidney stone needs a surgery. We really try, and if it's safe and your labs look okay and your urine's not infected and your stone's small enough, to just give patients some time to hopefully be able to pass these stones without us needing to do any sort of surgery. Again, that's kind of a shared decision-making process with your urologist about how eagerly do we jump into surgery, or how much time do we really give you to try and pass these stones. So oftentimes stones that are unable to pass, we'll give you some medications. And if that's not working, we kind of jump into procedures. So most folks, and I'm guessing a lot of folks that are signed up here tonight, have had kidney stones before. The most common thing that we give is a medication called Flomax or Tamsulosin. And what that is an alpha blocker type of medication. It relaxes some of the smooth muscle within the ureter, which will give you a higher likelihood of passing the stone. Now, there's a lot of kind of mixed studies that have come out to say, how helpful is it? Some studies may suggest that larger stones tend to have a higher likelihood of passing with Flomax, where it might not make a huge difference. I'm a proponent of it. I think in general, it's a pretty safe, cheap, well-tolerated medication. So I think if you're miserable with a kidney stone, the potential side effects with the medication don't necessarily outweigh trying to take that. So I usually tell patients, we want you hydrating well. We want you taking Flomax to see if you're able to pass this thing. We give you some other pain medications to make things more manageable as you're kind of working through, what we call a trial of passage or medical expulsive therapy of that kidney stone. And we also mentioned uric acid stones can be dissolved. Now, if you have a large stone that is sitting within the ureter, most of the time we're not going to be able to give you medications that are able to rapidly dissolve the stone. And really, uric acid are the only ones that do respond, better to changes in the pH of your urine, which will allow them to dissolve. So some patients who have non-obstructing kidney stones, so stones that are not in that drainage tube, but higher up in the kidney, I refer to them generally as problems waiting to happen, not anything that's actively causing an issue. So with these uric acid stones, if we know that you have them, we know that we've gotten a litholink test, oftentimes we can give you medications that will help shrink those down in size. So it's again kind of a shared decision-making process with your urologist based on the size and location and the type of stone that you have. There was another question going back to the litholink test. Can the PCP order it? Yes, they certainly can. PCPs tend to be masters of a lot of different things that us urologists are not very good at. So in general, if you're considering doing a litholink or you want your urologist to review it, I generally recommend seeing a urologist to kind of go through that. There is a little bit of nuance into interpreting those, but PCPs, for the most part, should be able to order them. I tend to order a lot of them, again, because my patient population tends to be more of the recurrent stone formers and the large stone formers, but really any patient that wants to learn a little bit more about their particular risk. And I do think they benefit from that. So kind of jumping more into treatment. One of the more common procedures that we do here in the US is a procedure called ureteroscopy. What that is essentially a procedure for a stone that is not passing or larger stones potentially that are up in the kidney, where we take a small camera, we put it into the bladder, a smaller camera that then goes from the bladder up the drainage tube, up that ureter, where we can directly visualize the stone. The nice thing with this is we can put little instruments through the scope. Some smaller stones that are, maybe less than 5 millimeters that are just having trouble passing and need a little help. Sometimes we're able to take a small basket, pull these stone fragments out relatively atraumatically. So that's kind of a quick, easy way of getting these things taken care of. Oftentimes, if the stone's a little bit too big to pass, we actually have to take a laser fiber, what we call holmium laser. We fragment these stones to much smaller pieces and then either let those stone fragments pass or sometimes use a basket to pluck out the smaller ones. In general, this tends to be an outpatient procedure. Usually takes between 30 to 60 minutes, just kind of depending on the stone location. Again, sometimes we get lucky and they have a really small stone that is really distal, really far, almost to the bladder and almost passing, and we can just pluck that out. Other times with larger stones, it requires a lot more work and sometimes can be more than an hour. In general, when you have a ureteroscopy, if the ureter looks absolutely perfect, we always will try not to leave a stent. And again, I'm guessing a majority of folks on here have either had stone surgery before or have had stents before. They're not everyone's best friends. That's probably an understatement. So what a stent is just a hollow plastic tube that allows that urine to drain safely from the kidney, bypassing that area of either blockage or trauma or swelling to get down to the bladder and protect the kidney, to make sure there's no infection trapped there and to really just let that kidney cool down from the blockage. While stents are no fun, it's really your safety valve that keeps you from having even more pain. Usually when that scope goes up into the ureter does not like it. It had a stone that was causing lots of blockage and swelling, a scope that then is going up, causing even more swelling and irritation. So if a ureter is really beat up from a stone being there, and then we put a scope up and then we don't leave a stent, patients tend to be just as miserable, if not worse off than they were before the surgery, because that swelling, once the stone is gone, now expands, completely closes off, and makes patients completely obstructed on that side. So oftentimes patients will come back 24 hours after surgery with no stent and say, I feel worse. I'm having fevers. My kidney's super swollen on a repeat scan. And then we need to urgently put a stent back in. So we always try and get away with not leaving it. Unfortunately, it's a bit of a judgment call during these procedures, but with ureteroscopy procedures, it tends to be a little bit more of a common theme to really just help protect the kidney. With the stents, sometimes we'll leave them on a string. That way you can just pull them out at home. I know it sounds a little bit daunting for patients who haven't had that, but the nice thing is it helps prevent another trip back to the operating room. Sometimes just based on judgment when we're in there, if the ureter's really beat up or we need to take a second look up that tube, we will leave the stent internal. That way it doesn't accidentally get pulled out too prematurely. So kind of moving on to other options, there's a kind of a least invasive option, which is what we call shockwave lithotripsy or ESWAL. This again is generally for stones that are unable to pass. And the way that this works is we use X-ray to target these stones. We make sure that we can see them on X-ray. And there is a fancy machine, which you see here pictured here, that we have down in our surgery center, that will prevent us from really needing to put anything else internal. So what it does is we target it with X-ray, send shock waves through the flank through this machine to really break up that brittle stone into much smaller pieces so those smaller fragments pass. So this is really a nice, minimally invasive way of taking care of these stones. There's a lower likelihood of needing a stent. There's a lower likelihood of infection because we're generally not putting any scopes on the inside. There's a lower likelihood of injuring the ureter or anything like that because obviously we're not putting anything internal. The downside to this is your stones have to be seen on X-ray, and sometimes that's a challenge for certain patients. In certain patients, we need the distance between the machine and where the stone is to be shorter. We need the stones to sometimes be a little bit softer. So there's some other things that your urologist can do to kind of counsel you to say, hey, what's your likelihood of this being a successful procedure? In terms of stone density and what we call skin to stone distance, there are certain things that we can kind of calculate to help predict, is this a good option for you? There's no incisions that need to be made. Generally, again, we're not putting stents on the inside. There are some exceptions to that. But this is a really, really nice option that's a bit less invasive. The biggest potential downsides is if you have really hard stones or you have larger stones, sometimes those fragmented stones can get stuck on the way out. You tend to have a little bit of a higher clearance rate with ureteroscopy versus shockwave lithotripsy, but the complication rate and the pain levels do tend to be a little bit less with ESWAL over ureteroscopy. So stones that are higher up in the kidney and stones that are in the top part of the ureter are really helpful, really good locations where shockwave is a really helpful procedure. Sometimes when those stones move a little bit farther down the ureter, ESWAL is not going to be indicated and unfortunately can't do it. So there was a question earlier, when is a KUB indicated? So KUB is an X-ray just looking for stones. So in some patients that were following stones over many months or years, it's a nice, cheaper, easier test that's quicker and less radiation than a CT scan. So some patients that I follow over long periods of time will get KUBs just to sort of track stones over time. The other reason would be if we're trying to see, has your stone moved or would you be a good candidate for ESWAL? The X-ray will allow us to say, yes, your stone is still in the same spot. It hasn't moved. And yes, we can see it. So yes, you would be a great candidate for ESWAL. So those are kind of the two times where we like to check X-rays. So we'll kind of move on to some other options. So unfortunately, some patients will get even larger stones. So when certain parameters are met, when stones get a lot larger, shockwave lithotripsy and ureteroscopy just won't cut it. There are more invasive procedures, unfortunately, that we need to do to really give you a higher likelihood of getting you stone free and having good success doing it. Some patients, we do what's called stage ureteroscopy, where we do the less invasive procedure, but we need to go up there multiple times. That tends to be a little bit more of a challenge for patients. It's multiple trips under anesthesia. If you have really large stones, it just doesn't really make sense to bring it back to the operating room 3 or 4 times to go up there and to clear out one stone when we have options of doing it a little bit more effectively. So that's where this procedure comes in handy. Because the word's very long and hard to say, we usually just call it a PCNL, a percutaneous nephrolithotomy. That's just a fancy way of saying we're going to do a little bit more of an invasive procedure. We make a tiny incision in the flank. We use our interventional radiology colleagues in general to help us gain access into the kidney. So there's a little needle that goes through the skin that allows us to get access directly into the kidney. And you can see on the graphic here, and I'll show a video here in a second. But with the radiologist's help, we get into the kidney. We will stretch out an area of the kidney, which allows us to then put a much larger instrument in there that really efficiently breaks up and removes these. Now, traditionally, this used to be a procedure that folks would stay in the hospital for 2 or 3 nights, potentially. More recently, it's typically an overnight procedure. I've been doing these primarily as an outpatient procedure in about 90+% of my patients. And I think that's really where things are moving for a multitude of reasons. I generally tell patients this is an outpatient procedure. There are exceptions for really complex stones, really hard stones. If we're worried about infection rate risks or bleeding risks, or see any of that intraoperatively, we kind of plan ahead. And most of the time we have a good idea of who may need to stay overnight. The nice thing again about this procedure, even though it's the most invasive procedure, it's just a tiny little incision in the back that's probably about 1/2 inch or less. And most people are back to work pretty quick with their stones moved a lot more effectively. So we'll see if we can get a video up and running here. So this is kind of a video. We'll start this. Let's see here. Perfect. So this is just, again, a visual of the bladder down at the bottom, the kidney up at the top, and a very large stone that's sitting in an area we call the renal pelvis of the UPJ. So typically with this PCNL procedure, at the start of the procedure, we'll actually help the radiologist by putting a little catheter that goes up the ureter and allows us to squirt a little bit of dye. So that's what you see going up the ureter right now. We also put a Foley catheter in the bladder to drain all the urine out through the procedure. This is kind of representative of an x-ray that we're shooting and some dye that we're squirting up into the kidney, which then allows the radiologist to kind of see that area a little bit better. A small needle that goes in through the back that allows us to directly get access into that kidney. So once we have a safe access point through there, sometimes we'll actually put a tube in that stays for a few days before the surgery just to make sure that we have good access to decrease the risk of infection and decrease the risk of bleeding. Some folks will do that, a week ahead of time. Some folks will do it same day, and that's really at the discretion of your urologist. So again, at this point, it allows us to then put a bigger instrument in there, a more effective and efficient way of breaking up these stones and kind of either basketing them out or actually vacuuming them out all at the same time. So again, with having a larger instrument rather than that smaller diameter, it allows us to just get these things clear, hopefully with just one surgery. Typically with this procedure, and again, all urologists have separate, some different nuances to how they treat this postoperatively. I generally will leave patients without a tube in their back. You can see here, there's a tube that's kind of hanging out of the back. I like just putting a stent internal if everything goes perfect. But occasionally, if there's a little bit more bleeding or a little bit of concern for infection, sometimes we'll leave both the stent in place, which you can see depicted by the blue coil there, as well as a tube in the back. So again, it really just depends on how that procedure goes and some of your urologist's comfort level with doing it. Again, I would say a vast majority of my patients will go home with just a stent in place. Keep that for a couple weeks just to kind of let the kidney cool down, and then that stent will come out shortly afterwards. So we kind of talked about treating, smaller stones with less invasive procedures like shockwave. We talked about ureteroscopy. We talked a little bit more about PCNL, which unfortunately is the best option for patients with really large stones. So you kind of have a little bit of middle ground where you have these larger stones that are maybe not quite big enough to warrant doing the more invasive PCNL, but maybe a little bit too big where we're worried this patient may require multiple surgeries with a less invasive type of technique. So I would say, current tools that we have are not exactly perfect, inadequate, maybe strong, but, there are, limitations to the scopes and the lasers and the baskets that we have. So there is a new technology that fortunately the urology group has been sort of part of. We've been part of their what we call an early market experience, getting early access to these types of scopes. So there's a procedure that we do. It's called CVAC. It's essentially a way of using a steerable ureteroscope to evacuate kidney stone fragments from the kidney without having to do the PCNL procedure. And I'll show a video here in a second, as well as some graphics. But this is a really, really nice technology that I think will be incredibly widespread here within the next year or sooner. Again, we were fortunate to be one of, I think, 6 sites in the country doing this. And I believe as of the time of this phone call, we've done more in the urology group here in Cincinnati than anywhere in the world. I believe Mayo and Harvard have done a handful, and actually the folks that invented them were up in Boston and now based out of California. So we've had a really great experience with this so far. And again, with this procedure, I'll show you a video in a second, but this is a way of really taking care of those medium to large stones, avoiding PCNLs for some patients, and really doing what we can to decrease the likelihood of second look and third look and fourth look procedures, clearing as many stone fragments as possible. So the other advantage of this is still an outpatient procedure. This is something that typically is 1 hour. I usually tell patients 60 to 90 minutes. It is rare that I'm lasering for more than 90 minutes. And some of these patients with really large stones, we're treating and vacuuming and removing all these stone fragments in less than 45 minutes. So this is just a quick picture of the system. What you see on the bottom part of the screen there is our flexible ureteroscope. So it's a new, innovative, kind of all-in-one system that integrates the flexible scope with a digital platform. It allows us to laser, to irrigate, to basket, and actually to vacuum out all at the same time. So this is something that, quite honestly, endourologists and urologists that have been treating stone disease for quite a while have said, why aren't we just vacuuming these stone fragments out? I hear it from patients all the time. Well, why can't you just vacuum these fragments out? Because of the diameter in the scope and kind of the technology with the flexible scopes that we've used in the past, it's been really challenging and really haven't had anything to date that has been this complete all-in-one system. So this is just another visual of kind of that flexible tip of the scope that allows us to navigate through the kidney. Again, kind of an all-in-one device that keeps everything in your surgeon's hand to allow you to break up and vacuum out these stones all at the same time. And part of the challenge with these larger stones that aren't quite big enough to require the most invasive surgery is, that kidney space where these stones are at is pretty small. Even though some of the pictures make it look like it's really large, it's a pretty confined space. So if you're lasering a really large stone, you get what we call the snow globe effect. You really get this dust that's just flying all over the place, and you can't really clearly see, have I gotten all the stone fragments? Am I leaving something significant behind that would be a problem later on? So this is where the CVAC device from Calyxo has really, really come in handy to really optimize patients and to decrease some of these second look procedures. And quite honestly, in some patients, actually avoiding a more invasive PCNL procedure. So this is just kind of an up close look at the tip of the scope. While we're doing the procedure, we're passively aspirating all the little dust particles that kind of create that snow globe effect. And then what we can do is we can remove that laser. And because we have a larger diameter inner area that allows us to suction, we're able to actually directly look at these stone fragments and pull out a lot of those, kind of smaller to medium-sized stone fragments that are remaining without having to go in and out of the kidney or without having to bring the patient back for a later surgery. So here's a quick video that the Calyxo team put together. So again, kind of showing the scope itself first. This will look a little bit reminiscent of how we described the ureteroscopy procedure. So again, multiple stones, higher stone burden. Generally, we'll start off by putting a little wire up into the kidney to allow us to then get access into the kidney with that scope. We directly visualize these stone fragments, take a little laser, break it up, and you can kind of see it zoomed in with the passive aspiration. This allows the really small stone fragments to kind of be suctioned out and aspirated while we're doing the lasering. I wish I was this quick in the operating room. This is a little bit of a sped up video, but you kind of get the idea. Again, we're getting much higher stone clearance rates for kind of those medium to larger stones. And I really think it's a great tool to have in our arsenal. I think we're really lucky to have this, in the greater Cincinnati region. So I would say at this point, I'm one of the higher volumes, if not one of the highest volume guys in the country doing this procedure. So I think it's a really nice adjunct, a really nice tool to have in the arsenal to really help any patients with stone disease, especially more complex stone disease, higher stone burden. I've had multiple patients say, hey, I had a PCNL years ago. It was a horrible experience. Is there anything newer out? And for quite a while, the answer to that was no. And so this is one of the more exciting newer innovations that we had. So yeah, thanks everybody for tuning in. We can certainly go into some questions now. We will try and send out a link. There's a link to the Harvard School of Public Health that we're trying to get out. I did have a couple questions about that. Let's see, a few more questions. So the CVAC procedure has been FDA approved. It's been FDA approved for a while. So I was actually part of the team that did the 1.0 device, and I probably did close to 50 or 60 of those, I think among the busiest in the nation with the 1.0 device. So the 1.0 device is a little bit different than the pictures in the video that we showed here. So that was kind of a way of blindly aspirating those stones out, which again was really, really nice for patients with larger stone burdens. What the newer 2.0 aspiration system allows is directly visualizing the stone. So in my opinion, it's safer, it's a lot more efficient, a lot less time under anesthesia, and really is going to be a game changer. The 1.0 device was a really nice tool to have, but the newer device is completely different. So even folks that aren't used to dealing with more complex stone disease, it makes it very, very user-friendly, and it's a really nice device. So yeah, that's been FDA approved. The procedure itself, I tell patients, if you've had a ureteroscopy before, it's pretty much the exact same recovery. The only difference is my work's a little bit harder in the operating room because there's generally a higher stone burden that we're taking care of. So the recovery is pretty similar. Typically, these patients will either have a stent ahead of time or a stent after the procedure. Fortunately, I'm still able to get this device into a vast majority of patients without having to have a stent put ahead of time. It does make it a little bit easier to do it and a little bit safer, but we've really run into only a handful of patients who we haven't been able to get that scope up in an unstented ureter. So recovery is typically pretty quick. I tell patients, you're going to have some irritation with the stent in place. You're going to have some pain for a couple of days, but the recovery generally with the CVAC is pretty quick. Another question, I've had many lithotripsy treatments over the years. Am I damaging my kidneys and subjecting myself to multiple treatments? So the answer to that in general is yes. Anytime that your kidney's blocked, you're causing a little bit of harm, potential scarring to your kidney. Anytime that we're putting instruments in and out of your kidney or shocking your kidney, there's potential damage, which is one of the reasons why I like to be a little bit more proactive, as I had mentioned with the LithoLink tests, and really getting to the underlying cause of these stones and trying to treat these stones, especially larger ones that are in the kidneys, being a little bit more proactive. That way you don't get to the point where your kidneys get blocked. So, it's kind of a fine line. If you have stones, we don't necessarily want them dropping while you're on vacation and then you're in a foreign country needing surgery. So there's sort of an art to, being proactive enough with larger stones versus not putting you through a bunch of unnecessary procedures. So yeah, anytime that you have a stone that drops and causes blockage, there's some potential damage. Most of the time it's a reversible type of damage, but if it's happening over and over, that can be a problem. So another really good question, what are the risks of a stone remaining in the kidney if it's not causing pain? So it's a good question. So I have a lot of patients that I'm following over time, mainly with x-rays, sometimes with CT scans or ultrasounds, but it's a bit of a shared decision-making process. If a stone is simply just sitting in the kidney, not growing, not blocking, the hope would be it's not causing any problems right now. Hopefully it won't moving forward. A high percentage of stones that are sitting up there will drop at some point. It's just a matter of when. So for patients who have non-obstructing stones that are remaining in the kidney, not causing pain, not causing blockage in less than 5 millimeters, we really don't need to do anything. In general, you can kind of check x-rays or other tests to just follow them over time. Now, as they get bigger, especially with the really large stones that we're considering treating with a PCNL, you can get some slow blockage of your kidney that isn't symptomatic, which is kind of addressing that point of what do we do if it's not causing pain. Some patients will have blockage for such a long period of time, their kidney just adjusts to being partially blocked. And that can be a problem because it can shut down your kidney function over time. So that's where, again, you need to talk to your urologist, really have them review the imaging tests, particularly the CT scan, a lot more carefully. Stones can grow. Stones are unpredictable. So even if you don't have a stone that's actively causing pain, that doesn't mean that, things might not change. I have some patients come in and say, "Doc, I just want to watch this thing." They call me 2 weeks later and say, "Okay, this thing has dropped, time to do surgery." Or I have patients I've been following for 3, 4, 5, 6 years that have these very slowly growing, non-obstructing stones that aren't causing problems. So a lot just depends on size, risk tolerance for certain people, and how healthy you are, if it makes sense to maybe put you through something elective. For really large stones that are growing, we tend to be a little bit more proactive, so you're not having issues with recurrent urinary tract infections, renal dysfunction, future pain, or if we're trying to avoid doing a PCNL in the future, sometimes stones that are big but not too big, we can kind of get to them with less invasive approaches before they get too big. So that's another reason to potentially treat these stones. But yeah, if they're not obstructing, they're small, you're not having kidney dysfunction and infection, certainly these things are safe to watch over time. There was a question earlier about potassium citrate and pH levels. So patients with uric acid stones, we tend to alkalinize their urine. So we don't want acidic urine that makes these stones actually get bigger. So we will give them medications like potassium citrate, lemon juice. There's a new medication that you can actually get on Amazon. It's called Moonstone. And what that will do is change the acidity of your urine to kind of help shrink these stones down over time. So that's something that in the office, we can actually check the pH of your urine to see how well we're doing. If we need to go up on dosage, down in dosage, things like that. In general, it's something that when we have a litholink, we have a stone analysis that allows us to kind of say, do we need to, give you those medications? Do we need to be aggressive about changing the pH? Or again, if you don't have any new stones that are there, some people would make the argument of just watching it. So there's another question. Is lithotripsy a possible option for calcium oxalate stones? Absolutely. One thing that we can measure is density of these stones. So again, there are certain types of calcium oxalate monohydrate stones that tend to be a lot more dense. There can be a little bit of a lower success rate if your stones are really large or really dense. So again, if you really want to avoid the more invasive laser lithotripsy, talk to your urologist, see how dense or not dense the stone is. Or if you have a history of these calcium oxalate monohydrate stones, sometimes that may say, hey, you might have a little bit of a higher likelihood of needing a secondary procedure. But if it's a borderline or smaller stone, I still think shockwave is a reasonable option. Now, calcium oxalate dihydrate stones tend to be a lot softer and tend to respond really well to shockwave lithotripsy. With laser lithotripsy, it doesn't really matter how hard those stones are. We have a laser that's going to break through any stones, regardless of how soft or dense they are. Another question, I passed a stone on one side, I have a smaller one hanging on the right. Does anything need to be done? In general, I would say no if you're not symptomatic. If you're not followed by a urologist regularly, I personally think it's helpful to kind of keep an eye on that. If it's something that's small, hopefully you get an X-ray or ultrasound in 6 months or 4 months or a year that shows that is stable and not getting bigger. The advantage of doing that is if your stone does get a little bit bigger and you're saying, I remember how horrible that was passing that last one or having surgery for the last one, it then gives you a little bit more autonomy, a little bit more flexibility to say, hey, I now know that this 2 millimeter stone has grown to a 4, has now grown to a 7. It's sitting there. I got this fun trip to Italy, or I'm planning on going to Mexico or going down to Florida for the summer, and I don't want to have to find some local hospital there. So again, I think that's a really nice opportunity to say, hey, would this be a candidate for shockwave lithotripsy if it's small enough? But if it's smaller than 5, generally we just kind of keep an eye on it. Nothing that needs to be done, by any means urgently. How long does it take a stone to form? Good question. My bad answer is it's very variable. Some patients will form stones just within a month or 2. Other patients, it's taken them years to form these things. So everyone's urine chemistry is a little bit different. Everyone's genetics are a little bit different. Without having old scans to compare to new scans, it's kind of hard to tell for each particular patient. But again, that's another reason I like to be a little bit more proactive with imaging, just so we can kind of track, if if we treated and cleared all your stones and 3 months later you have a couple 2 millimeter fragments, that tells me that you're somebody who's a lot more predisposed. And I've had, again, saw a couple patients today in the office that have had no new stone growth after forming a 30 millimeter stone 5 years ago, haven't formed anything. So each patient's a little bit unique. Usually it takes a little bit of a longer period of time. This is not something that's just popping up within a couple of weeks. Another question, is anesthesia needed for ESWAL? Yes. This is not the best way of selling this procedure, but with these shock waves going through your flank, it's kind of like somebody just punching you over on the side for a period of time. So you wouldn't want to be awake for this. So we typically put patients under anesthesia. You wake up and the whole thing's over. Another question, would these surgeries work for kidneys with lots of calcifications? That's, I think, where the question's going. Patients who have multiple stones or a higher stone burden, that CVAC procedure is a really, really nice option depending on the overall total stone burden. A lot of patients will have maybe one stone that's a little bit bigger, but multiple other stone fragments. So again, if we have a 1 centimeter stone and then 5 other stones that are smaller, it's nice having CVAC available. We can go in there, break these things out, and really vacuum out a lot of those fragments as well. Another question, does CVAC work for staghorn stones? So it can. Have I done some of them for staghorn stones? I have. It's definitely a way more challenging procedure, and by no means am I going to promise you I'm getting you cleared with one 90-minute procedure. But in certain patients who have contraindications to a PCNL, can't get off of blood thinners, can't have a PCNL for certain reasons, or some patients where the radiologists have trouble getting access into the kidney, or the staghorn's a little bit on the smaller side, what we call a partial staghorn. Certainly you can make an argument to try this less invasive technique. In general, I think it's going to be a lot more of a customized approach. I know I've beat that drum over and over, and I know it's probably not a great answer. Each case is a little bit different. I think if you have a partial stag that maybe has some branches but is 1.7, 2.1 centimeters, in somebody who's maybe had a bad experience with a PCNL or is on a lot of blood thinners, CVAC would potentially be an option. Now, if you have a complete stag filling your entire kidney or a really large stone, we can do CVAC, but it's going to be a long, drawn-out process that probably isn't in the patient's best interest. So, again, a lot depends on the hardness, prior stone surgeries, how complicated or how many calyces the stone is filling. What size is considered a large impassable stone? Usually for stones in the ureter, I use 5 millimeters as a cutoff. 5 and less, I tend to try and encourage patients to pass these without surgery. When we get above 5, I start talking about potentially getting something surgical on the books. Same thing goes for stones that are in the kidney. If we start forming larger ones, we'll at least broach the subject of, hey, do we want to try a shockwave lithotripsy? Another question, with KUB x-rays, do they have good predictability of problems to come? In general, yes. Not all stones can be seen on x-ray. Uric acid stones don't show up. There's some other softer stones that don't show up great. If patients are a little bit more obese, if patients have lots of bowel gas or are constipated, sometimes the x-ray pictures aren't perfect and can miss smaller stones. Or again, if you have a stone that doesn't show up on x-ray like a uric acid stone, that can be a little bit deceiving. So a CT is nice to have kind of as a baseline to say, yes, we know that there are stones here. Usually what I'll do if we're just following those is check an x-ray shortly after that, just to confirm that we can see them and to make sure things are lining up between the CT scan and the x-ray. Another patient with a couple patients. So I've had over 17 stones passing or need surgery, multiple surgeries and lithotripsies. I'm at risk for kidney disease. Absolutely. There's always a potential risk, which is, again, why we like to be proactive with prevention. The bigger risk is if your stones are blocking the kidneys for longer periods of time. In general, a lot of these surgeries are very, very safe to do. In general, doing that to clear a larger stone is probably going to be safer for your kidneys long-term rather than either a slow progressive blockage or, multiple high-grade blockage episodes that are requiring ER, stents, multiple procedures, things like that. Another patient, I had some fun ones here. I just had 19 stones removed about a month ago. How long can it take? So I kind of touched on that before. everybody's a little bit different. Most of my stone forming patients, we check some imaging tests about 6 weeks or so after your surgery, just to establish a new baseline to kind of answer that question. And usually about 4 to 6 months from then, assuming there's nothing large or no problem seen on that post-operative ultrasound, we'll get some other pictures just to kind of answer that question and say, hey, what is your stone growth rate? Are you forming these things quickly? And my ideal patient is when we can say, hey, you haven't had any stones in a couple of years. Let's see you back in a year with an x-ray. Hopefully it's another boring x-ray without any sort of stones, and kind of get to the point where we're saying, okay, you got a 2 millimeter stone. It's been 2 millimeters for several years. Let's just keep checking that once a year or every other year, x-ray or ultrasound, depending on the stone composition. Another question, are all the docs in our practice doing the CVAC? As of right now, no. There's a smaller group of us that were part of that early market experience and have access to the newer 2.0 scopes right now. In the near future, we're going to be rolling it out. At this point, there may be just, I'd say probably 8 or so. I could be wrong on that. I know the number's climbing as we're getting more experience with this. Part of the problem is because it is such a new procedure, the company is needing to kind of keep up with the demand. And I think they're seeing pretty quickly that there's a pretty significant demand. And with how successful it's been and how much we've really liked it, I think we're seeing the CVAC numbers creep up. So I think if you fast forward, 6 months, 12 months, I would say a majority of our urologists who are doing stones are going to offer this. At the very least, there are folks in every single office throughout the city, Northern Kentucky, Cincinnati, that do offer it. So, even if you're not up on my neck of the woods, obviously I'm happy to see you, but there's at least one urologist in every pod of throughout the city that has access to this device and has experience, especially within the early market experience. Does insurance cover CVAC? So yeah, so it does. It's again similar to a ureteroscopy. So from a patient standpoint, insurance has been good about covering this, and from a patient perspective, it's usually less procedures, maybe a little bit more time under anesthesia one time, but a higher stone-free rate, a lower retreatment rate, and hopefully lower issues down the road with additional stones dropping. So some other questions, the greater Cincinnati area, hard water in this area, stone belt. This area of the Midwest does tend to be a little bit higher. There are some good studies kind of looking at different areas of the country that have higher incidence of stone disease. Some people would argue maybe that's the hard water. Some people would argue, is that the dietary changes from folks in this area. So I will say my practice is always very busy with stone patients. I obviously see preferentially those patients, but I do think we see it a little bit more here than in other areas of the country. Another question, is it common to have stones in the bladder? It's not super common. Most patients who have bladder stones, if it's something small, it may have just been, we caught that scan on a day that you just had passed a kidney stone, and that's all it is a small stone that passed. If that's the case, those usually pass. Now, patients who have bladders that aren't working perfectly or incomplete bladder emptying can form bladder stones, and that's kind of a little bit of a different beast, a little bit outside of this scope. But there certainly can be dietary components of that. Most of the time, it's more of an obstruction component. The guys with enlarged prostates that aren't emptying their bladder all the way that form these. Some of these surgical techniques, similarly, we'll go in with a scope and a laser and break these up and kind of flush these out. Another question, insurance question: does this cover CVAC, Medicare, Medicaid? That's a great question. I'm by no means a insurance expert. We do have a whole billing department that can kind of answer those in more detail. So if you're worried about your insurance coverage and you do see somebody who's doing CVAC, typically we're running all that through the insurance. I know right now, because we only have access to this device down at our surgery center, some patients' insurance won't cover it at the surgery center for whatever reason, even though it's more cost effective, it's cheaper, it's safer than doing it at a hospital. However, that is still kind of in process. There are certain folks' insurance that just won't cover surgery down there. So until it's a little bit more widespread and available to all the community hospitals, for right now, we're trying to get all of our CVAC patients taken care of efficiently down at our surgery center. Another patient, should I report every time that I have blood in my urine? If you haven't been worked up, absolutely, you need to see a urologist. if you recently had a kidney stone procedure or something along those lines, we kind of expect some intermittent blood in the urine moving forward. So I wouldn't say every time, but if it's something that hasn't been addressed or it's something that's more long lasting, I would definitely touch base with whatever urologist you had seen last to sort of review imaging and or scope procedures to make sure that there's nothing nothing else that's going on that could be causing the bleeding. A few more questions. How long do you wait in hopes that the stone will pass if you're in horrible pain? Is there a medication that can reduce the pain? So yeah, it's it's a bad answer, but if your stone's small enough, we tend to give folks, sometimes up to a couple weeks to pass it. If patients are in, 8, 9, 10 out of 10 pain, horrible pain, can't tolerate it, sometimes what we'll do is put a stent up there to help alleviate that pressure on the kidney and then get them, set for an elective outpatient procedure. Sometimes we're able to coordinate all on the same day, just kind of depending on a multitude of factors. If you're in horrible pain, usually the safest thing is getting into the emergency department or getting into the office as soon as possible to get the imaging to figure out what's going on. There are multiple medications which can help. We talked a little bit about Flomax, higher likelihood of passing these things. There are medications that, again, I would consult your urologist, but there are really strong medications like Toradol, which we don't want folks getting if we're going to do a shockwave lithotripsy or Eswal. But if you have a stone that is not going to require that, Toradol is a medication that works well. A lot of different anti-inflammatory medications work well. Narcotics, there's some mixed data out there. Usually we still prescribe those. We really try and minimize those as possible, but some patients' pain is just so severe that even if we're giving them, Toradol, Tylenol, Flomax, Pyridium, all these other things, it's just not enough. So sometimes it's getting the stronger narcotic opioids on board, and other times it's just getting you in to have surgery sooner. And I tell patients, again, it's a 80, 90% chance that you pass a smaller stone, but that's still 10 to 20% of patients that might not be able to pass a 5 millimeter stone or 3 millimeter stone. So if you're in extreme pain, if you've been to the ER multiple times, usually that's a sign that, hey, call your urologist. You probably just need this thing taken care of surgically if you're not making any progress with getting this thing passed. Next question. I have uric acid stones. X-rays don't see them. That is correct. X-rays generally will not pick up on those. Ultrasound is usually how we follow folks. Ultrasound is good, not great. It's usually how I follow chronic uric acid forming patients. It tends to generally overestimate the size of stones. So if there's something large, usually we're not missing it. I kind of use the ultrasound in conjunction with CT scans. If we're seeing something larger, I like to get a CT scan to really prove that the ultrasound is accurate. So in general, it's accurate. Can it overestimate the size of stones? Can it miss small stones? Can it underestimate stones? Yes. So that's why I like to have that CT as kind of a base. Another question, why does gastric bypass surgery make it more at risk? So what that does when we change the way that you digest things with a bypass surgery, in general, the biggest thing is it changes oxalate absorption within the intestines. So patients tend to take in a lot more oxalate, even if their diet hasn't really changed a whole lot. So these patients tend to be a lot higher forming calcium oxalate stones. So again, there are observation that we do with shockwave, or sorry, with KUBs to really track patients that might be at higher risk. We wouldn't recommend every patient with a gastric bypass has to come see us for a CT scan. But if you've had a history of stones and you're thinking about getting gastric bypass, it is nice to have some sort of established relationship with a urologist. That way, if after the surgery, there's a lot of dietary changes that happen around the time of any sort of bypass surgery. Sometimes it's a challenge drinking as much fluid or hydrating as well as you would like. So it's kind of a combination between lots of dietary changes, not being able to drink as much water as maybe they have in the past, as well as some changes in some oxalate absorption. Last question here. Is there a certain time of day is better to take Flomax? In general, we tell patients to take it before going to bed. There is a really low risk of having a little bit of dizziness or lightheadedness, a little bit of a drop in blood pressure. So if you're taking it, 30 minutes before going to bed, if you are a little dizzy, the hope is you're already asleep, so it doesn't really impact you a whole lot. Is it the end of the world if you take it in the morning or take it in the afternoon? Not really, especially if you're not having any sort of side effects with it. But if you are worried about the side effects, or you have issues with low blood pressure or other things that tend to make you dizzier or a little lightheaded a little easier, usually we tell folks to take Flomax in the evening before going to bed. Well, thank you guys for coming. This was a great turnout. Lots of fantastic questions. I believe the next slide will give you a link. I'm sure you guys already have access to the website, but if anyone's interested in making appointments to see any of our team, we'd all be happy to see you. Hopefully that link for the Harvard Oxalate worksheet got sent out, and this will be available later on to review. That way, if there's any other questions, again, hopefully this is a good resource. But again, thanks for taking time out of your night. We really appreciate everybody coming, and feel free to give your local urologist a call if you're worried about any of these issues or have this as a history. Thanks, and have a great night.